Thank you, Chairman, sir. Thank you, Rupa, for inviting me here. It's a pleasure to be here talking on a new drug of which we know very little. Time will tell us whether we are right today or not. And with whatever we know, we are here to share whatever we know with you. So the don'ts, we will go through 15 don'ts quickly. The first don't is do not start if it is not approved for that indication unless it is a registered trial. Yeah, so the first don't is do not start the drug if it is not approved for the indication unless it's a registered trial. So what are the indications? I think this has been discussed, but for the benefit of the audience, moderate to severe ulcerative colitis for induction as well as maintenance in biologically naive or patients who have had previous TNF failures, or as a first line before azathioprine in a patient who has received steroids before we start azathioprine. We have limited data in this area, but this is one area which is emerging, and as a second line before vedolizumab. So in these patients, how do we start? We start with an induction dose of 10 milligram twice a day and give it for 8 weeks. And the second indication which is emerging is in acute severe ulcerative colitis who have failed first line therapy with intravenous steroids. So here the dose is 15 milligram twice a day for the initial 3 days, followed by 10 milligram twice a day. So in these patients, we have to reassess at 16 weeks. At 8 weeks, if the patient doesn't show response, we extend the therapy for another 8 weeks. And at 16 weeks, if the patient is not showing any response, we stop the medication. So we stop the medication at 16 weeks if the patient doesn't show any response. So it is a jack of all trades. It is a JAK inhibitor, and it is emerging as a useful drug in the management of ulcerative colitis, especially in our country because of its cost and its oral route in contrast to biological agents. So the second don't is don't give a higher dose than what is needed. Side effects are higher with higher doses. There is more venous thromboembolism, more hyperlipidemia, and more infections. So to reduce the chances of side effects, use only in the prescribed dose. And the prescribed dose is 10 milligram of the drug twice a day for 8 weeks. And at 8 weeks, we assess for remission. If there is remission, and in TNF naive patients, we step it down to 5 milligram BD. So it is important to step down to 5 milligram BD so that this is the minimum effective dose for this drug, and we continue at 5 milligram BD. And if when the patient is on 5 milligram BD, the patient loses response, that time you can again escalate it back to 10 milligram BD. Re-escalation has been shown to recapture response. However, if the patient was a patient with TNF failure, then we need to continue on a higher dose, that is 10 milligram twice a day. So if a patient has gone into remission, we then take a decision based on whether they are TNF naive or TNF failure. If they are naive, we continue at 5 milligram twice a day. If they are failure, they go in at 10 milligram twice a day. If the patient doesn't go into remission at 8 weeks, we continue the 10 milligram twice a day for 16 weeks therapy. And at 16 weeks, if the patient doesn't respond, then there is very limited data what we do with them, maybe 5 milligram or 10 milligram twice a day. If at 16 weeks, the patient doesn't show response, we stop the medication. And if the patient is in remission, you should de-escalate it to 5 milligram twice a day to minimize side effects. So what is the dose in acute severe ulcerative colitis? Is tofacitinib 15 milligram twice a day or as 10 milligram thrice a day, basically 30 milligrams in a day. If they respond in a week's time, we step it down to 10 milligram twice a day. If they don't respond in a week's time, we should look for other options like surgery or other biological agents. So the third don't is that we should assess for any risk for thromboembolic events. So we should look at the routine things, very simple: obese patient who has family history of coronary artery disease, patient has had a cardiac event in the past, patient has low ejection fraction, patient has a recent history of MI, and morbid obesity, malignancy, immobilization. These are all risk factors for venous thromboembolism. And we look for these. And also in a selected group of patients who have developed venous thromboembolism, only in them should be testing them for various prothrombotic disorders. Otherwise, it is not routinely indicated. So a quick history will tell us whether there's a chance of DVT or PT in the past or a ischemic heart disease. So there's a black box warning which says that there's increased risk of myocardial infarction, stroke, and thromboembolic events. The more important thing here to understand is there is a meta-analysis which has been done, which has been shown that the OR is 1.07. That means 1.07 times greater risk. But this study is underpowered. You can see that the confidence interval is crossing 1, and you can see that the upper end of the confidence interval is 2.34 times. That means there is a chance when we get more data that it may be as high as 2 times increased risk for cardiac events and 5.59 times increased risk for MACE events. So right now we don't have sufficient data, but the confidence interval can range from 1 to 2.34. The fourth don't is if a patient is having an active infection, do not start the drug. Whether it could be a localized bacterial infection, a viral infection, tuberculosis, hepatitis B, or a fungal infection, avoid starting the drug when the patient has active infection. So you should in India screen for hepatitis B and tuberculosis, minimum HbSAg and total anti-HBC. And for tuberculosis, we do IGRA and a MON2 and a chest CT. And if any of these things, recent study from AIMS, from Vineet's group has shown that if you do a detailed screening for tuberculosis and diagnose tuberculosis, then you should always combine it with antitubercular prophylaxis so that you do not have reactivation of tuberculosis. The fifth don't is hyperlipidemia. So if there is pre-existing hyperlipidemia, hold on. Get the lipids to normal levels and then start this medication, and also keep checking their lipid levels initially at 4 weeks and 8 weeks and then subsequently every 3 months to see whether there is increase in the lipid levels. And if the lipid levels go up, then you should treat them and ensure that you get lipid lowering agents. The sixth don't is pregnancy. As Dr. Devendra Desai already highlighted, we have very little human data. There's only one study from Uma Mahadevan, who has a lot of studies in this area, which says that, I'll just show that in the next slide, that there are 11 cases of maternal exposure and 14 cases of paternal exposure to tofacitinib. And there were 15 healthy newborns and 2 spontaneous abortions and 2 MTPs. No fetal or neonatal death or congenital malformation, but the data is very limited. So as of now, it is contraindication until further data arrives. The seventh don't is lactation. As Dr. Devendra Desai mentioned, tofacitinib is present in the rat milk at twice the concentration as the serum. So that means it is getting secreted into the breast milk. So it should be avoided, and hence it becomes a contraindication for tofacitinib use. The eighth don't is if patient has already a malignancy, we should avoid using tofacitinib because tofacitinib has been associated with non-melanoma skin cancer, lymphomas, and solid tumors, but there are only 11 patients in this. The real life series is actually lower than what was seen in the Octave trial. So, but still this is a warning to hold on in these kind of patients. If you have abdominal symptoms and signs in a patient of abdominal pain, distension, please look for perforation, because there are 3 cases reported of perforation in the Octave trial, no perforation in the real world series, and any patient with any abdominal symptoms should have prompt evaluation for the abdominal symptoms. So be vigilant there. The 10th don't, start or continue if counts are low. So don't start tofacitinib or continue if the counts are low. The critical points are hemoglobin of less than 9. Neutrophil, today morning we debated whether it should be 1000 or should be higher. But basically, if there is reduction in neutrophils and WBC count and lymphocyte count and hemoglobin is low, hold on and correct these parameters and see if there is associated iron deficiency, B12 deficiency, whatever are the causes, correct them, get the hemoglobin to above 9 before you start these patients on tofacitinib. The 11th don't is hypersensitivity, because this is rare. It can happen in the form of angioedema and urticaria. And if it happens, discontinue, do not restart. The 12th don't. If a patient has severe hepatic impairment in the form of child C cirrhosis, this use of tofacitinib is not recommended. In others, there has been shown to have increase in liver enzymes. So routine LFT monitoring is recommended. Interrupt the therapy if there is evidence of any drug-induced liver injury. The 13th don't. If there are concomitant immunosuppressants, avoid it. We do not have data in ulcerative colitis, but in other conditions like rheumatoid arthritis, which Dr. Devendra Desai alluded to, combination with methotrexate has had untoward outcomes. So do not put a patient on double immunosuppressive agents, because tofa itself is an immunosuppressive agent. The 14th don't is age groups. At extreme ends of the age, we have very limited data. Elderly people and the pediatric age group, we have very, very limited data. So if we can choose other agents, it may be better till we have studies which are directed in this age group. The 15th don't. Do not continue beyond 16 weeks if there has been no response to the therapy. So no point continuing it beyond 16 weeks, declare it as failure and look for other options. So to summarize, Mr. Chairman and Dr. Rupa, don't start it in patients who are likely to become pregnant or lactating, or those who are pregnant. Avoid it in those with prothrombotic risk factors. Avoid it in those with malignancy. Avoid it in those with hypersensitivity. Avoid it in those with concomitant immunosuppression. Avoid it in child C cirrhosis. Use it in only approved indications unless it is a registered trial. And don't be lax. Watch for the abnormal LFT, watch for hyperlipidemia, watch for pancytopenia, be vigilant for GI perforation, and watch for herpes, TB, and reactivation of viruses and infection. Thank you.
Thank you, ma'am, for that wonderful presentation. I think you quite extensively covered what we should be careful with while the patient is on tofacitinib. And I think we'll have questions towards the end.
Okay.
And the next talk is going to be managing side effects while the patient is on tofacitinib. And the talk is going to be Dr. Ajit Sood. Dr. Ajit is head of the department, Dayanand Medical College, Ludhiana. He requires no introduction. He has extensive experience in managing IBD patients, and is not possible to find out Ajit Sood in IBD symposium. So over to you, sir.
Thanks. And thanks, Rupa, for the invite. Both Devendra and Usha have emphasized that TOFA is a good addition to the existing therapeutic armamentarium of for patients with IBD. And even if we follow do's and don'ts very strictly, when we use a new drug, certain adverse effects are bound to happen. And let's see what are the common side effects. The indications have been highlighted: induction and maintenance of moderately severe ulcerative colitis, and some other indications are under evaluation, like patients with severe ulcerative colitis who do not respond to steroids, where we use it as a rescue therapy. The other indication is whether we can use it as a primary therapy without using steroids. And the third is whether whether patients with arthralgias or arthritis associated with IBD, we can choose TOFA as a drug. Please mind that these indications are under evaluation. Today we can't say that we can use this. The next is that there is some evidence that TOFA may work in Crohn's disease, but the existing data suggests that it's not effective in Crohn's. So as of now, we should not be recommending TOFA for Crohn's, but off-label use, some people are using and experiences like to accumulate. Now, what are the factors which influence the development of adverse effects? The important factors could be the age, ethnicity, existing of certain risk factors like what Usha showed. There's a long list of factors which can predispose the patient to develop extent thrombosis. So if a patient is prone to develop thrombosis, we know that the TOFA can enhance the development of venous thromboembolic phenomena. The other factors are previous or concomitant medications, comorbid conditions, and previous infections. And the other factors are disease activity and the dose. She's already highlighted that the dose should be optimal. You use 10 milligram twice a day as long as it's required and try to de-escalate it as soon as possible. When we count or when we list the common side effects, nasopharyngitis, headache, arthralgias may be counted as the common side effects, but they are not of severe degree and they are not of major clinical significance, so we don't really discuss them in detail. The major side effects which are bothersome are infections, hyperlipidemia, development of venous thromboembolism, major adverse cardiovascular events, what we say as MACE, risk of malignancy, and again, raised creatine kinase is reported as a side effect, but again, this is not of great importance. Starting with infections, the risk of overall infections, we need to know that even minor infections we have to count as side effects. The other infections, what can be grouped are serious infections which necessitate hospitalization or need parenteral therapy, or opportunistic infections, which commonly are not supposed to happen in an immunocompetent person, but they happen when a person's immune system is suppressed. So we have to take into account all the three kinds of infections. When we look at the OCTAVE trials, which first emphasize the efficacy of this, if you look at the adverse effects, they're not rare, they're rather pretty common. But when we look at the infections or serious adverse effects, then the incidence is around 3.5% to 5.6%, or you can say 3.5 to 6%. And when we come to the infections, when we talk of serious infections, the incidence may be varying from say 1 to 1.3%. So it's serious infections are not a major issue. But when we talk of overall infections, then nearly 15 to even 40% patients may have some infections, including minor infections. Specific point for discussion is herpes. The incidence varies from 0.8 to as high as 5.1%. Who are the people who are more likely to develop herpes? People who are on a high dose, that means 10 milligram twice a day, or who have been previously exposed to anti-TNF agents. If we keep ourselves confined to 5 milligram twice a day in a patient who is not previously anti-TNF agents experienced, the risk of herpes is pretty low. Now, once herpes happens, what is the pattern of herpes? Thankfully, most of the patients, they develop a very minor illness. It's a single dermatome involvement or two dermatome adjoining dermatome involvement. It does not lead to multidermatomal or dissemination. And if we look at the patients in whom we need to stop the drug because of severe herpes, it's very minimal. None of the patients in OCTAVE trials had to stop drugs, but data from UC clinical program in Europe showed that 8 out of nearly 1157 patients, the drug was stopped because of severe herpes infection. So need to keep it in mind that the risk of herpes is there overall in patients with IBD and patients who are on other drugs like steroids, azathioprine, or biologics. And when we combine the two drugs like azathioprine with biologics, the risk is more. And if all three drugs are given together, the risk is still higher. Tofacitinib is associated with 2 to 6-fold increased risk, and the risk is dose dependent, as I mentioned. And it's not dependent on the duration of therapy. Now, these are just some of the pictures which show that how herpes looks like. All of you are well familiar with this. The diagnosis is mainly clinical. Rarely when we have a patient with a severe disease or we can't differentiate it from herpes simplex, we need to go to PCR estimation from the fluid of the lesion vesicle. We should preferably start treatment within 72 hours of the development of the lesion. And in uncomplicated cases, valacyclovir 1 gram 3 times a day for 7 days is good enough. But if lesions are appearing even after onset of valacyclovir, we can go to intravenous acyclovir, the dose being 10 milligram per kg. And the duration of treatment is from 7 to 10 days. And we generally continue treatment for 2 to 3 days after the resolution of the skin lesions. Now, question is that once somebody has herpes, we treat. What should we do with the TOFA? Should we stop it for good or can we restart it? If a disease is mild, we may even stop it. But if there's a concern and we are really concerned that it may not flare up, we can withhold TOFA for some time and start as soon as the vesicles have receded and the skin lesions have completely disappeared. I mean, the safe time could be to start a few days, say 5 to 7 days after the skin lesions are over. For prevention, 2 vaccines are available. Initial vaccine which came was Zostavax, live vaccine. The recombinant vaccine is also available now, Shingrix. And as a matter of fact, all patients with IBD should be considered for vaccination. And among the vaccinations, among the various diseases, infections which can happen in patients with IBD, herpes is one of the major infections which is preventable with vaccine. Both are effective. Recombinant vaccine, Shingrix, is more effective, but cost and availability in our country is an issue. Today in our morning discussion also, everybody is really wishing that we get vaccine soon. So this was about herpes. Coming to tuberculosis, like for anti-TNF agents or for other biologics, tuberculosis is a risk more so for us in India. Same way, even for small molecules, we can't close our eyes to the fact that small molecules also cause immunosuppression to almost the same degree. So whatever precautions have been recommended, whatever workup has been recommended for screening a patient before starting biologics, that holds true for screening, or that holds true for evaluation before starting tofacitinib. COVID and TOFA is an important concern. Do patients on TOFA carry a high risk of acquiring COVID? Going by the results from the different studies, IBD Cure Registry, the answer is no. Do they have more severe disease? Or do they increase or they have a higher incidence of mortality or hospitalization or requirement of mechanical ventilation? The answer is no. When we compare TOFA with all other drugs, more than one drug, or with biologics, the chances of requiring hospitalization and chances of requiring ventilatory support or requiring hospitalization rates are comparable compared to biologics or when we use 2 drugs for IBD. We should not withhold vaccination when a person is on TOFA. The safe policy could be to withhold TOFA for a week on either side of administration of vaccine. This is just a safety measure. Otherwise, we should not withhold vaccination. And the response is fairly good. The response may be little less as it holds true for all biologics. That as the response is a little less as compared to a healthy population. But there is a fairly adequate response to the vaccine. This was about infections. Coming to hyperlipidemia or dyslipidemia, which Dr. Usha and Devendra showed that hyperlipidemia is a concern. There are a few important points to remember that patients with IBD generally have lipids which are lower than a non-IBD patient's healthy persons. And when we use TOFA, what happens? There is an increase, and this increase starts appearing 4 to 6 weeks after starting TOFA. Important point to remember is that TOFA increases not only total cholesterol or total triglycerides, it increases LDL, and at the same time it increases HDL also. So when we calculate total cholesterol oblique HDL ratio or LDL oblique HDL ratio, what really matters as far as risk of developing coronary artery disease is concerned really does not change much. So it is a concern, but not a very major change which predisposes a person to the risk of CAD. And remember, it's reversible. But that doesn't mean that we forget it. There are some patients who got inherent dyslipidemias. So let's see how we handle those patients. So this is what I've just now explained, that the ratio does not change much. And how do they translate into MACE, major adverse cardiovascular events? There is a slight predisposition, but patients need to be monitored for lipids 4 to 8 weeks after starting this. And if a patient has other risk factors, as shown by this open label extended study, in which 7 patients developed cardiovascular, 7 patients developed complications, cardiac complications. Of these patients, 5 had multiple cardiovascular risk factors. So if a patient has pre-existing cardiovascular risk factors, even some elevation of lipid profile matters. Now, this is how we look at cardiovascular risk stratification. We can divide patients into low risk, moderate risk, high risk, or very high risk, or extreme risk. Patients who have already an episode of coronary artery disease and carries some other predisposing risk factors fall into extreme risk. So we need to stratify the patients, and patients who fall into category A or category B of very high or extreme risk. If there is a slight increase in the value of LDL or non-HDL cholesterol, suggesting going up to even 50 or 30 milligram, it means that we should give it importance, and we should consider treatment with statins. Venous thromboembolism. If we look at the incidence of venous thromboembolism in patients on tofacitinib, 10 milligram and 5 milligram, the overall patients, the risk was only 0.1%, and the risk of pulmonary embolism is 0.3%. The risk is there, but quite low. And again, we have risk factors known for predisposition to venous thromboembolism, and we should try to stratify a patient according to the known risk factors. If a patient has a major VTE episode, we should avoid using tofacitinib. But if a patient has VTE and has other concomitant predisposing factors, we can correct those predisposing factors and we can consider reuse. But if there was no predisposing factor and it is attributed to TOFA only, in that situation we avoid reusing. Malignancy and TOFA, what is the relationship? The risk of malignancy is higher, but it's very infrequent. If we exclude non-melanoma skin cancer, the other malignancies which have been reported are lymphoreticular disorders or CRC, and the risk is same as has been reported in patients with RA, where TOFA has been used in the long term, and the risk of developing malignancy on TOFA is comparable to risk of developing malignancy in patients on biologics. And other important observation is that non-melanoma skin cancer, which occurs in these patients, is, though I mentioned, is not very frequent, but most of the patients where it happened was older age, and they've had a previous episode of the same cancer earlier, and they have been TNF failures, which are previously reported as risk factors for developing non-melanoma skin cancers. So it's generally a result of multiple risk factors rather than just using one drug. Coming to the last adverse effect of creatinine kinase, as its excretion is through the kidneys, the CK values rise, but they are not of any clinical significance. So not much point in discussing. Now, after going through various adverse effects, I think I have painted quite a rosy picture that frequently the side effects do occur, but they are manageable. They are not very severe. and not very devastating. But what does FDA say? February 2021, FDA issued a black box warning, which everybody has been referring to, that the serious heart-related complications and cancer risk is high, so it should not be used so freely. It should be kept after a TNF failures. So this was about TOFA. In December 21, they found that this is more of a class effect, and the warning has been extended to other anti-TNF agents also. So based on the same factors, that the initial results raise safety concerns, and all JAK inhibitors, not only TOFA, all JAK inhibitors should not be used before using anti-TNF agents. Now, this safety concern was based on this study in which cardiovascular and cancer risk with TOFA was evaluated in RA patients. And the important thing I've mentioned is in the red, that the patient population was cardiovascular risk enriched population. All these patients, they were carrying some or the other or more than one risk factors for developing cardiovascular risk factors. None of them had a clean medical history. Now, this is FDA's viewpoint. Let's see what worldwide post-marketing safety surveillance show. Now, this is reported by Ruben and his group, and they agree that whatever has been reported in the, or whatever has been shown in the Octave trials, the side effect profile is the same. I mean, the side effects do occur, infections is a concern, but they are not of very serious nature, or they don't carry a high mortality. Now, when we, again, coming to the same point, when we look up at the adverse events and dyslipidemia are not rare. Mild infections do occur, but thankfully, serious infections and herpes zoster, when we look at the proportions of patients developing adverse effects, are not very common. The last, that what does international consensus on the prevention of venous and arterial thrombotic events in patients with IBD says? Out of 19 statements, 2 statements are focused on tofacitinib, and I'll read it for you. The TOFA can be associated with the dose-dependent increased risk of venous thrombotic episodes in patients with RA with risk factors for VTE. According to available evidence, no increase in the risk of VTE has been observed in the overall ulcerative colitis population treated with tofacitinib. The second statement is that TOFA is not associated with an increased risk of major adverse cardiovascular events in patients with UC. So there is you can say, a bit of contradiction between FDA's approach and post-marketing surveillance studies and these guidelines by the international consensus. So to sum up, TOFA is an important addition to the existing armamentarium of ulcerative colitis. More so, it's an important drug for resource-constrained countries like India. Adverse effects are not uncommon, but the real-world evidence is more in favor of acceptable safety profile. The infections like herpes, tuberculosis, COVID should be discussed before starting this. Hyperlipidemia, MACE, VTE, malignancies should be at the back of our mind when we use TOFA. Thank you. Thank you.
That was a great talk, Ajit. Thank you very much. Now, after these 3 great talks, I'll be failing in my duty. I think, to my experience, is the first time anybody's organized a TOFA symposium in India. Thanks, Rupa, for organizing this. I must confess one thing, that for this molecule, my immune boosters or confidence boosters have been rheumatologists. I never had experience from that. These guys keep tweeting left and right the rheumatoid arthritis and psoriatic arthritis, and these guys boost that. Sir, use it. There's no problem. But I think, Ajit, this symposium has brought a lot of clarity in using this molecule. I don't think many of us experience on using this molecule, but I think this was great listening to you. Because of paucity of time, we are lacking behind. There are 5 minutes. There are 3 mics there. We must ask the questions. I'm sure there are a lot of lingering questions in the mind. If I can start the first question to Devendra, I think you'll have to give the mic to Devendra. Devendra, what is the scenario? Would we be able to stop, after bringing the remission, good remission, the 5 ASAs in these patients?
So the question is, can we stop 5 ASA when there is a good remission, right? Okay, so basically now we have the precedence that in patients who respond to biologics, we stop 5 ASA. Similarly, there is some but not very definite evidence that we can also stop 5 ASA when patients are on azathioprine. Similarly, if we have good remission like what we mentioned, we should be able to stop 5 ASA.
Okay. I think another question for Ajit. In Bombay Hospital, we have a lot of renal transplants. And there's quite a bit of burden of IBD in these patients. What is the scenario like, using TOFA in post-renal transplant patients, the safety profile?
With immunosuppressives like cyclosporin or TAC or other immunosuppressives, that should not be used. We should avoid this. When we count the drug interactions, besides antitubercular or antifungal drugs, immunosuppressive agents should be avoided because the level of immunosuppression goes down tremendously.
Since a major concern, I think we all have is the herpes zoster. At least, I mean, my question is, at least in TNF naive patients, can we start with 5 mg BD, then assess for the response at 8 weeks, then step up the dose instead of coming with the 10 mg followed by 5 mg?
I think we should start with the recommended dose.
Okay.
The risk of herpes, as I've been saying again and again, is there, but the risk is not very high. I mean, we should be alert. We should be aware that herpes can happen. I suppose we should be watchful. I mean, the moment it happens, if it is mild, we can really start the treatment and it goes away. So for fear of herpes, we should not decrease the dose because the response is likely to be suboptimal.
Right. I think then someone has a
Yeah.
question.
My question
Can you
is,
introduce yourself?
yeah,
please?
myself is Dr. Shailendra Jain from Bhopal. My question is that suppose a patient who is having latent tuberculosis and we started the rifampicin INH. After starting the rifampicin INH, how much days after that we can start the tofacitinib?
I think Dr. Usha, you'd like to take that question.
Yeah, in these situations, INH prophylaxis is advocated, and that is advocated for minimum 3 months. And you can start it alongside with the immunosuppressive agent. So you have to just start INH prophylaxis alongside.
And my second question is that after the achieving the clinical and complete remission, what are the chances or stopping that after the stopping of tofacitinib, what are the chances of the relapse of the ulcerative colitis?
I don't think we have sufficient data in this area. Right now, most of these patients are either in remission and post-remission are in the maintenance phase. So I don't think we have sufficient data to say how many will relapse after we stop the agent. So right now we have data only on induction and maintenance period.
Normally, we say tofacitinib is as a second line therapy for the TNF failures. Since a major concern in India we face beyond steroids is the cost with respect to biologicals. Any role for tofacitinib before biologicals?
Yes, definitely. I think that is where is the emerging role of tofacitinib. After we give steroids, whether we give tofacitinib before we start azathioprine or for AZA failures before we go on to biologics. So that is where is the area where tofacitinib will get positioned finally. And data from India has to emerge on this, but whatever the international data is telling us that only.
So quick questions now
Uh,
from Partha and from, yes, please go ahead.
So, is there any data on use of tofacitinib as on-demand therapy just to treat the flares?
Yes, I mean, start and stop or stop and start therapy is possible with TOFA. That is a big advantage of this. There are studies which have shown that when we stop TOFA, for whatever situation it happens, like say pregnancy or patient has to undergo some surgery or some other complication happens, like say herpes and patient's treatment is terminated. When we restart therapy, more than half of the patient, they can easily recapture the response. So stop and start therapy may be a trend tomorrow. We can't say at the moment, as Dr. Usha mentioned, that for many things we don't have enough data at the moment, but we have a perception. And if my perception is that as we accumulate more safety data on TOFA, it's likely to go up the ladder as far as positioning is concerned.
I think just a quick question, only one.
Yeah. Dr. Virendra from Bangalore.
Someone in front here. He's been waiting for quite some time. So
Not
this is the
exact-
last
yeah.
question for
Yeah.
this session.
So I'm Dr. Neeraj Nagaish from Jaipur. Not a question, but just a majority of our patient going to be 9 or less hemoglobin. So a cutoff of exactly 9 for tofacitinib or any opinion or
I think
experience.
Dr. Desai, if you can quickly take this question.
So I think it would not be difficult to get the hemoglobin up quickly and start with tofacitinib.
I think we close the session now. We had a very, very brilliant interactions, and I think, but certainly, of course, a lot of people would like to ask questions to the speakers during tea breaks or lunch. Thank you very much. Thank you very much.
Thank you, chairpersons. And thank you, excellent speakers, for this first session. I think we'll quickly go on to pure ulcerative colitis. We have interesting case discussions coming, and all your questions are partly going to be addressed there, as well as your questions you can ask at the same time. The speaker for the next talk, and I ask Dr. A.S. Puri to please come on stage. And the chairpersons for this session is Dr. J.R. Mahapatra and Dr. Kiran Peddi. So Dr. J.R. Mahapatra is Senior Consultant Gastroenterologist from the Peerless Hospital in Kolkata. And Dr. Kiran Peddi is again Senior Consultant Gastroenterologist at Yashoda Hospital, working a lot on inflammatory bowel disease. So maybe you'd like to introduce the speakers.
I don't think Dr. Puri needs an introduction. He has his career in GB Pant Hospital, and after GB Pant, he has joined Medanto for timing. So without much introduction, without wasting any time, I would request Dr. Puri to go ahead with his lecture.
Thank you, Dr. Mahapatra, and thank you, Dr. Rupa, for giving me this opportunity to be here this afternoon. Thank you, MSN. And I'd just like to say that what you heard from the previous 3 speakers, if this was a grammar class, is about future tense. I'm going to be talking about past tense and, of course, present tense. Because as far as I'm concerned, the amino salicylates, we started with them. Hopefully, we'll stay with them. Sulfasalazine today, 1941. So it was discovered by Nana Schwartz, Sweden, and she became the first female professor of medicine. So approximately 75 years old drug, and just rounding it off, versus tofacitinib, if we take from the FDA, about 3 years. So we're comparing a drug which has a track record of 3 years versus a drug which has a track record of 75 years. Essentially, this is the pram and baby concept. The sulfapyridine is is the pram and the baby is the 5-ASA, and the function of the sulfapyridine is essentially just to transport it to the colon. Somewhere in the end of 1990s, we switched to 5-ASA, and that currently is the most commonly prescribed drug. So as far as aminosalicylates are concerned, it's the drug of choice for induction of remission and for maintenance of remission in mild to moderate ulcerative colitis. It has not been evaluated for induction of remission in severe ulcerative colitis. And mesalamine is as effective as citalopram for induction of remission. Somewhere in around 2000, there has been a paradigm shift. We all know that, and I was in the generation that we switched over from citalopram to 5-ASA. For the prime reason, it's the ease of dosing and the reduced adverse effect, which are almost only related with the sulfur component, and only one which is related to the 5-ASA. I'll be discussing about that. The exception is in the condition of extraintestinal manifestation. If you have patients with spondyloarthritis or central and peripheral arthritis, then it's better that you switch back from your 5-ASA back to citalopram. So that is the only exception where it is used currently. This is just to show you a cartoon diagram. That is the role of the colonic bacteria to split the citalopram into two components. And the reason why I'm showing is it's the sulfur moiety that is associated with the complications, with the adverse events. And now we've done away with this. So the adverse events of 5-ASA are practically negligible. In the Iraq war, this concept came of smart bombs, and it was almost as you could pre-launch briefing that you're not supposed to hit hospitals, you're not supposed to hit schools, and you're supposed to hit only military targets. So the pharmaceutical industry took cue of this, and they said, okay, now we will devise drugs which will act directly on the colon. We're not going to, no drug will be released in the small bowel. You won't need a carrier molecule. You don't need the carrier molecule, no side effects. So that is the concept of smart bombs and smart drugs. And this is the reason, this is one example that I've given. So these are the micro pellets. Each micro pellet of 5-ASA is coated with polymethyl acrylate, and then there is a hydrophilic matrix, and then there is an enteric coating. So you could say this is a riddle wrapped in a mystery inside a conundrum. And that's most of the drugs, whether it is Vega's OD or Masacol OD, and this is the technology that they use. The preparations that we have today for 5-ASA are tablets, the foam enema, the suppository. We don't have the gels in India, but in the West, they are available. For topical therapy, specifically for E2 disease and E1 disease, there is enough meta-analysis to show that 5-ASA enemas are better than hydrocortisonemas. That has clearly been proven in all the meta-analysis, yes, but you can even combine the two. So if you have a patient who's not responding to the 5-ASA enema, then you can add the hydrocortisonema, and that will give you better results. What we need today, if Mr. Bharat Reddy is here, we probably need budesonide MMX enemas, which are not yet available. So there is some homework for team MSN to do. The adverse effects of citalopram, as I said, are almost entirely due to sulfur. In general, a safe drug, but occasionally, very occasionally, you would see agranulocytosis, drug-induced fever, drug rash, and a hypersensitivity pneumonitis. The only one adverse event associated with 5-ASA, which is relevance in today because most of us use, and we learned this the hard way, is the triad of interstitial nephritis. So very rarely, approximately 1 case per year, sometimes 1 in 2 years, you'll see a patient of ulcerative colitis who's on 5-ASA, and he develops fever, and we ask for a urine test that shows a sterile pyuria, and it's been ingrained into us. Anybody with fever and sterile pyuria has genitourinary tuberculosis, and we go on sending endless samples. Then you call the nephrologist and they look at the non-oliguric renal failure. And if they're in doubt, they will do a kidney biopsy, and sure enough, that shows interstitial nephritis. So that is one condition. If the dose is too high, then you reduce it or you have to stop it. But there's some practical issues, and these came to fore only this year when the temperatures crossed 45 degrees in the northern part of the country, that the 5 ASA suppositories contain a fat, which is basically magnesium stearate. And in the temperatures which are currently in Gurgaon and NCR, 45 plus, this is one of my patients sent me this picture that all his suppositories are melting. So it's a simple solution. You ask them, the moment you cross February or maybe March, then you put these suppositories in the fridge and that solves the problem. And they write this warning on the box. So if you buy, I think this contains 20 or something, but if you buy solitary, then the patients didn't know. So this is, I thought, a practical point which can be emphasized. Most of us are from the northern part, and you'd hardly have anybody coming from Kashmir or Sikkim or the Northeast. I'll now go on to immunomodulators. The two drugs that are widely used in India are azathioprine or Azoran and 6-MP. 6-TGN beginning to make an entry, but not yet quite there. This paper in Lancet 2022 mentioned that Imuran or the immunomodulators are perhaps the most commonly prescribed drugs in ulcerative colitis after 5-ASA. And the Western data shows about 60% of these patients would have received immunomodulators. Unfortunately, the Indian data, and to quote the Indian data, this is from the ISG task force. Please concentrate only on the ulcerative colitis, and you can see, although this is about 10 years old, only about 30% of the patients in India have been exposed to immunomodulators. How do they act? Well, they are purine analogs. So when the cells are rapidly dividing, specifically the white cells, these are the building blocks because they're part of the DNA and the RNA. So if you have the purine analog, which is like poor quality purine, so cell collapses and therefore these cells, they die. There is inhibition of proliferation of the lymphocytes. And if there are no lymphocytes, there's no inflammation. So that's how they act. What is their place in current management? They are very useful adjunct to corticosteroid in steroid dependent. So every time you think your patient is going to become steroid dependent when you're lowering the dose, then the safest thing to do is to first add an immunomodulator for maintenance of remission in patients who relapse on monotherapy. So if you have a patient who's only on monotherapy with 5-ASA, you add the immunomodulator if he has a minor flare. The success trials and the SONIC trials have showed us that when you combine the immunomodulator with the Remicade or biologicals, then immunogenicity goes down. In general, these are slow-acting drugs with a peak effect only at 8 to 12 weeks. I thought I'd show this thiopurine metabolism because it has a bearing on a recent paper that came. So we know that this is the prodrug, non-enzymatically converted into 6-MP. And then there is an interplay between 3 enzymes. And the 3 enzymes are xanthine oxidase, HPRT, and TPMT. Now, the active component becomes 6-MP, becomes TIMP, and ultimately this will form 6-TGN. But the most important drug is the TPMT, and this is shunting away by just acting as a methyl transfer. So if you have 6-MP here, after methyl transfer, it becomes methyl 6-MP or methyl MP. And the ratio of this is roughly about 10:1. And my next slide will further clarify this ratio. The third enzyme, people almost forgot about it. And they said, xanthine oxidase is a dead end. So when you have a xanthine oxidase, that will convert it into thiuric acid, and then that's a dead end, it doesn't. But apparently, the Danish workers in the paper published only last month, they read this diagram more carefully, and I'll come to that. But first, I wanted to show the ratios. So this is from that paper which appeared only last month. and concentrate only on the ASA. So 42 patients given either 6-MP or Azoran. At 6 weeks, the TGN level is 330. At 6 weeks, the MEMP level is 3,134. So I've done the maths here and the ratio is 9.6. And this is exactly what I said, the ratio is 10:1. So if it becomes 40:1, then that makes it a hypermethylator, which means that all the drug that you're giving is going in here. And this causes hepatotoxicity. So clearly you will have to do. So coming to the Danish workers, they said, why don't we inhibit this xanthine oxidase? And we already have a drug. So the drug that we have is allopurinol. So if you inhibit this drug, then a part of this will flow in this direction, also in this direction. So your 6 TGN levels will go down. So this is exactly what they showed. This was, as I said, just last month. Low dose Imuran and allopurinol versus monotherapy with azathioprine. And this was a RCT done in Denmark. I can't pronounce the first name. I cannot pronounce the city in which it was done, but it's a Danish study. So clearly they showed that there is a benefit if you use, and the dose of the dose of Imuran that they used was only 50 milligram. Otherwise, we are taught that the dose should be anywhere between 1.5 to 2.5 milligram per kilogram. So here they avoided the side effects by just giving 50 milligram and combining it with. Now everybody is quite aware of this, that there is genetic polymorphism in this, more so in the West. 90% or so were the wild type. The homozygous is probably 1 in 300, heterozygous 10%. If you have homozygous and you've done the testing, then best thing is to avoid giving this drug. If you get a heterozygous, 50% of the drug, and if you have wild type, then you need to give the full dose. We have two choices, either testing for TPMT deficiency, either we can do genotyping or enzyme activity. In general, enzymatic activity is far more reliable because first it is done, the methods are different. This is done by HPLC, this is done by PCR. The enzyme activity is influenced by 5-ASA, this is not, but a very high level suggests refractoriness to IM immunomodulator therapy because everything is being shunted away. And conversely, a low level is predictive of myelotoxicity. The problem in India is it's even lesser. So we will have homozygous. If it's 1 in 300 in the West, it's much lower in India. So probably it doesn't make it cost effective. My students, one question that they will always ask me was, for them it was a dilemma. So they said, if ASA is the pro drug, then why don't we start with 6-MP? We should be giving 6-MP to everybody. Why are we giving ASA? So the answer is here. The bioavailability of Azoran is 80%. The bioavailability of 6-MP is less than 50%. It has a lot of interaction with food, and therefore the absorption is so erratic. And it is also felt that the adverse events are more with 6-MP. So because of these reasons, everybody across the board uses Azoran or azathioprine, and we don't start with 6-MP. But having said that, there are some patients, you start the patient on Azoran and he'll come to you, I feel very uneasy, I get a discomfort, it's not a pain, mild, and you just switch to 6-MP and it goes away. This is well documented, but I don't think I have the reason why this happens. The important question is thiopurine toxicity preventable? And I put the choices here, yes or no. And the answer is both yes and no. And as per my slides will answer that. So the adverse events of as immunomodulators are two broad categories. One, they're idiosyncratic, and the other is dose dependent. So if it's idiosyncratic, they're not preventable. If it's dose dependent, it's definitely preventable. The prototype idiosyncratic is pancreatitis and bone marrow depression. Usually this is far less common because the prototype for the dose dependent is bone marrow suppression. So I'll take the adverse events. I've quoted Dr. Ajit Sood, he's sitting here right here. This is quite an old paper, but this is possibly one of the few papers dealing with the adverse effects of azathioprine and 6-MP in India. 111 patients, overall about 4% developed adverse events. What was slightly odd in this paper was that pancreatitis was the commonest. So 7 out of 18, almost 30%, almost. And whereas all the previous studies from the West, they have emphasized it is the bone marrow depression. In their study, 4 out of 13 had to stop the drug. So again, 1/3 had to stop the drug. And the needs for dose reduction was 10 out of 18. This is data from Medanta. It's not yet published. 350 patients who were exposed to immunomodulators. 11 developed serious bone marrow depression. And the entry criteria was a TLC less than 2000. Sorry, a TLC less than 4000 and an ANC less than 2000. So this was the inclusion criteria. And we had mostly patients with ulcerative colitis. And the presentation in most patients is asymptomatic. So when bone marrow depression does occur in patients with exposed to immunomodulators, it is usually asymptomatic. Occasional patient will have a petechia or something. We had used mostly, as you can see, it's azathioprine. And this is the nadir values of TLC and ANC. The time to manifestation, some values are missing, but you can see most of them occur after 8 weeks. And this is what I had mentioned. It's a slow drug to act. The peak effect usually around 12 weeks. Sometimes it occurs very late. And in most patients, we had to, dose reduction was there and only 4 patients had to stop. But those of you who have a very keen eye would have noticed this thing in the block, in the blue block that I made. All the patients that we had were males. So I wanted to ask the other people, Dr. Ajit Sood and the others, is this a one-off observation or has it been a male predominance has been noted in other studies? Azaran-induced pancreatitis, one slide to show you, patient started 2 weeks ago. She comes with abdominal pain and a lipase around 3000. For some reason, she didn't have a mileage going up, but within almost 3 days or so, it was back to normal. We did a CT, nothing much to show except a small focal collection. And this patient made an uneventful recovery. We're not going to challenge her again because the next time she may have a much more severe attack. I mentioned that most of the time it is mild thrombocytopenia, mild bone marrow depression that occurs, which is asymptomatic. This is an exception. This young boy who was on Azaran for more than a year, he developed this extensive rash that you can see, petechial rash. And this is his pancytopenia, hemoglobin less than 6, TLC 900, platelets 16,000, retic count absent. So he had an aplastic anemia. And this is the peripheral smear. And if you notice, there is a erythroblast sitting right here. And there's no RBC, no WBC that can be seen in this slide. We did his bone marrow, and you can see his bone marrow is totally acellular, and all that you have is fat over here. And if there's fat, that means the marrow is completely dead. Unfortunately, we lost him, and this patient had been on Imuran for almost 18 months. More commonly, what you see is Imuran or thiopurine-induced leukopenia, which I call TIL. The frequency is anywhere between 6 to 13%. Usually occurs in the first 5 months. Median is about 60 days, so that's 2 months. Most of these cases are mild and they require only dose reduction. And possibly there might be a higher risk with 6-MP versus azathioprine. This slide shows you the futility of testing for TPMT, because if you have 100 cases of TIL, thiopurine-induced leukopenia, then only 25 or so, 25% or 1/4 will have a homozygous TPMT, which means, in other words, that 3/4 is unrelated to TPMT. The AGA guidelines mention clearly, this is 2017, in adult patients with IBD being started on thiopurines, the AGA recommends screening for TPMT, and they say it doesn't matter whether it's enzymatic or genotyping. but the strength of recommendation is conditional and the quality of evidence is poor or low. Lastly, I'm just going to touch on Nudix superfamily or NUDT15. And in the metabolism of 6-thio, it is NUDT converts it into 6-thio GMP. And we can now test for the genetic testing. There are 3 polymorphisms or haplotypes available. And this is the one, if you have this haplotype, arginine replaced by cysteine at 139, it's extremely sensitive to 6-MP and azathioprine. And I think there have been at least 3 studies. The first one was from Dr. Desai's group. The second one is from Rupa's group. For shortage of time, I'm quoting only the most recent one from PGI Chandigarh. This is NUDT polymorphism evaluated in about 120 patients. Almost all of them were ulcerative colitis and leukopenia in 28%, which is fairly high. Intolerance to thiopurines in 4%, pancreatitis in 1.6%. Again, this is in tune with the published literature elsewhere. But they found NUDT polymorphism in 13 out of their 119 cases with an odds ratio of 3.6. So 3.5 times more risk of having thiopurine-induced leukopenia in these patients. Whereas the TPMT polymorphism was documented only in 5 patients. Now comes the strange thing. This is not a one-off observation. In Far East Asia, in Korea, Japan, NUDT is much more common. So that's the Mongoloid race. And we in India, we are Caucasians and still we are showing so much NUDT polymorphism. So this is an unanswered question. And I think I'll stop here. This is my last slide, the summary. The 5-ASA and immunomodulators are the most commonly prescribed drugs in IBD. 5-ASAs largely replace salzopyrin. Immunomodulators are used as steroid-sparing agents or to reduce immunogenicity. They're also associated with serious adverse events, which may be idiosyncratic or dose-dependent. And NUDT polymorphin is now more common in India versus TPMT. Thank you for your patient listening.